Morning. Welcome to another session of short course of clinical epidemiology. Today, we have Dr. Andrew who will be presenting on record checklist. So we have had previous sessions on stroke checklists and gas checklists for observational studies, cohort studies. But this is a slightly add-on checklist to the usual stroke checklist for an observational study, wherein the data is collected from routinely collected healthcare data like a registry. So we look forward to listening to Dr. Andrew. Without any further delay, I'll hand over to Dr. Andrew. Thank you.
Morning, everyone. Today we'll be looking at the record checklist. So we'll start today's session with clinical scenario. In your OPD, you have a 65-year-old gentleman who's come with recurrent episodes of syncopal. You do a Holter on him, and that shows a paroxysmal atrial fibrillation. So you explain the condition and the diagnosis and the treatment options to the patient, and you explain about the need for anticoagulation as well. So the patient seems a little upset at the news, but he agrees to take his medication. In subsequent OPD visits, the relative state that the patient has become more withdrawn. He's not showing any interest in his daily activities. So on referral to a psychiatrist, he's then diagnosed with major depressive disorder. Now, as a clinician, you want to know, does being diagnosed with a chronic medical condition precipitate depression in anyone? And other specific diseases that have a higher risk of causing depression. So to answer this question, we're going to look at the study today, which is on medical conditions and the risk of subsequent major depressive disorder. It's a nationwide registry-based cohort study, which was done in Denmark. This was published in 2024. The data was collected from 1995 all the way to 2022, and the study was finally published in 2024. So this is the article we're looking at today to try to answer these questions. So what type of study is this? This is a retrospective cohort study, and it's a registry-based study. What is a registry-based cohort study? It means the study data has been taken from routinely collected registry data. Now, the Danish Health Registry has details of all the patients who are diagnosed with any medical condition, the prescriptions they have given. The whole entire country's data is collected into a single place. So that gives a valuable source of information, and that allows to be able to do a cohort study and enables you to follow patients long-term quite easily. Now, the registry-based cohort studies, these are useful for certain type of research questions. Some of these are natural history studies where you want to follow up the natural course of a disease through time. And because the follow-up is over a long term, measures of effectiveness and safety can be easily followed up. Now, registry-based cohort studies, they usually have very limited inclusion, very limited exclusion criteria. Most patients with the condition will be included. So that increases the generalizability of the study at the end. If you want to follow up for long-term benefits, doing a cohort study over long term may not be very feasible. But if you have the data in the registry already, it makes it easier to do a retrospective follow-up of these patients. And because there's a large amount of data, you can follow up rare diseases. And in cases where randomization is unethical or it's not feasible, like in case of surgical interventions, there also registry-based studies have an advantage. Now, we've already seen the stroke checklist. The stroke checklist was these are reporting guidelines for reporting observational studies. You can apply them to all observational studies, which means they can be applied to a registry-based cohort study as well. However, there are some pitfalls of using the stroke checklist when you're dealing with a registry-based study. Some of the things are, it does not take into account misclassification bias. Misclassification bias is in any registry. Any patient with a medical condition is given a specific code. Like in our own discharge summaries, we have ICD coding for all the diseases. Now, so the quality of the data depends on whether the coding is done accurately in that registry. Now, if there is any mistake made by the patient person who's coding, or if the code is not specific for a disease, if there's overlap between multiple diseases, that would reduce the quality of your underlying data. Now, the stroke checklist does not take all that into account. There are other issues like missing data, other unmeasured confounding factors. These are all not really evaluated in the stroke checklist. So to overcome these deficiencies, the record checklist was created, which stands for reporting of studies conducted using observational routinely collected health data. So this is not a separate checklist on its own, it's created as an extension to the stroke checklist. As an example, on the first column, we have the stroke checklist items where you have, so remember these are reporting guidelines. So it gives you details on how to frame the title of your study. Now the stroke, if you remember the stroke checklist, you have a checklist of total of 23 items. The record checklist is an extension, it's an expansion of 6 of these points where they are expanded to include data on the underlying registry as well. So for instance, in the stroke checklist, the study title the study design should be included in the title. That's the only thing that is mentioned in the stroke checklist. But in the record expansion of that stroke checklist, it says the underlying registry should also be named in the title, and the time period in which that registry data was collected, that should also be included in the title. So it's an expansion of specific points. So we will go through this checklist one by one today. For instance, in the title of the study, also this study was done before the record checklist had come out. So they have actually used this study, they have mentioned they have used only the stroke checklist to report the study itself. But we will use the record checklist to see what they have missed out and whether there's any further data that is available. So now in the title of the study, they have indicated the study title design, which says that it's a retrospective cohort study. But if you're using the record checklist, they should also mention what is the underlying database that they have taken the study from, which here is the Danish Health Registry. That should also be mentioned in the title. They should also mention the time period of the study, which is 1995 to 2022. These are information I got from the reading the article itself, but ideally it should have been mentioned in the title itself. Now, one other thing is that remember when you do a PubMed search, you search for mesh terms. Now, until 2015, there was no specific mesh term for a registry-based study. Only subsequent to that, PubMed came up with a specific term for registry-based studies. So even despite that, it's important to mention that it's a registry-based study in your title itself. So someone who's searching for your article, searching for registry-based studies can easily find it. Explain the background for the study is that major depressive disorder is the third largest contributor to life years lost. But we don't routinely screen for depression in our OPDs. We know that certain medical conditions do have a risk of development of major depressive disorder, but the exact relationship, how much is the risk with one medical condition, does the risk go up with subsequent medical conditions? Those are all things we don't know. And if some diagnosis, like for example, if malignancies have a higher risk of causing depression, those are all things that we want to try to answer from the study. The hypothesis of the study is that the onset of medical conditions is associated with the subsequent development of a major depressive disorder. The objective was to calculate the relative risk and the time-dependent relative risk for major depressive disorder after the onset of these medical conditions. So what are the key elements of this study design? Is that all hospitals, like I said, the Danish National Patient Registry has details of all admissions, emergency room visits, prescriptions, and all medical prescriptions. So the data was taken from these two registries. The method of the study was that they had started collecting data either at the birth of the patient or in 1995, whichever came last. Now, once the patient has entered the study, they have given a 5-year washout period. The purpose washout period, meaning during this washout period, if the patient developed either a medical condition like diabetes, hypertension, or anything, or if they developed depression, then they were excluded from the study. Now, the purpose of this washout period is that the hypothesis that these patients already had these conditions before they were included in the study. So they were simply picked up a little later. So to allow for washout of these cases who had pre-existing conditions, they are given this 5-year washout period. Subsequent to this 5-year washout period, these patients were followed up through time from 2000 to 2022. The exposure that they have looked at is onset of any medical condition, whether that's diabetes, hypertension, any musculoskeletal disorders, or a malignancy. That would be the exposure. And the outcome they have looked at is the onset of major clinical depression. Now, just to explain that in graphical how they have done this, let's say a patient enters the study here at 1995. Let's take this example of patient A. He enters the study here at 1995. During this 5-year washout period, he does not develop any medical condition. So during this 5-year washout period, he does not develop any medical condition. Therefore, after post the 5-year washout period, he is included in the study. Now, in 2010, he develops an onset of hypertension. So that is his exposure. Then, subsequent to that, in 2012, he develops diabetes. That is the second medical condition that he has developed. Subsequent to that, in 2018, he develops major depression, which is the outcome of interest. So once he develops the outcome of interest, we stop following up his data. So this is patient A, where clearly he has had an exposure and he has had an outcome. Now let's look at the example of patient B. This patient also, we have started following up at 1995. But during this 5-year washout period, he develops multiple sclerosis in 1999. So this is a medical condition that has developed during the washout period. So therefore, he is excluded from the study, which is from the study analysis, which is looking at development of any medical condition causing depression. However, remember so multiple sclerosis was classified under neurological conditions in this particular study. So even though he's developed multiple sclerosis here, we can still include his data when you're looking at cardiovascular conditions as an exposure factor. You can still look at the data if you're looking at endocrine conditions, because he has not developed that exposure in the washout period. So he would be excluded from the overall analysis for any medical condition. But if you're looking at endocrine or hematological conditions, then this data would still be included. So in other conditions, his data would still be included. He does not develop any exposure, but finally he develops an outcome of depression in 2018. So this patient had an exposure to multiple sclerosis in the washout period, not included for that analysis, but he's included in the other analysis. Now let's look at patient C. Now patient C, he again also is included in 1995, but during the washout period, he develops major depression, which is our outcome of interest. Now, because he has developed the outcome of interest in the washout period, he cannot be included for any analysis and is excluded from the study. Now, the next point in the record checklist is that there should be a description of the participants who have been included in the study, which is what we have just gone through previously. Also, in the record, now in the stroke checklist, because it looks at any observational study, it just asks you to describe the inclusion-exclusion criteria and the participants. Now, the record checklist goes a step further. Now, here, because we are extracting data from a database, we already said each patient will have a specific code given within the database. So, the record checklist states that if you're extracting data from a database, the codes that were used to identify each patient in the database should be mentioned. For instance, in this particular study, hypertension was given a code of C0204 for any drug code, and dyslipidemia drugs were given a code of C10 and an ICD code of E78. Now, these should be specified in the study so that someone who wants to replicate the study can go to the same database and they can extract the same data from that. Now, this may be a problem in certain studies, like this was done from a pharmacological database. The pharma company may not want to share their own coding for the disease. So if it is not possible to share, then the study should include an explanation as to why it was not provided. So here in this study, because it's from the Danish Public Health Registry, they have provided us the ICD codes and the disease and drug codes they have used for each condition. One other factor is that if you are extracting data from multiple databases, for instance, in our study, they've taken the patient data from the Danish patient registry. They have taken their age and other demographic factors from the civil registration system, and they have taken the income and those details from the Danish labor market account. Now here, so in this country, each person is given a specific identifier number. That same identifier number is used in all three databases. So if you search for that ID for that patient, you can extract the data out of these databases. So if you're doing this system where you are extracting certain information from one database and certain information from another database, then you should describe how you have, either through a graphical method, you should describe how you have extracted the data, which they have not done for this study. So I put up other examples from other studies where they have done that. For instance, if you're looking at myocardial infarction, this one particular study where they have extracted data from three databases, which is primary health data, hospital data, primary care health data, and from the National Disease Registry. So they have taken a mix of patients from all these three registries, and they've given percentages of certain number of patients were found only in one. Certain patients' details were found in two registries, and certain patients' details were found in all three. So you should give a Venn diagram like this, saying how much you have extracted from each database. In addition to that, like in our study, apart from the Venn diagram saying how much you have extracted from each database, you should also give a flow chart saying the patient's age, sex was taken from this database, but the patient's income was taken from another database. So you should split up the Venn diagram and explain how much what data was taken from which database. Now to describe, the next step is to describe any efforts to address any potential source of bias. Now, in this particular study, they have done matching for the important characteristics of age, sex, and onset of illness. They have also used Fox proportion hazard model, which is used for regression analysis. The other methods which can be used to reduce bias in observation studies are stratification and propensity matching. Just to give an example of how they have matched the patient. So let's take this patient, individual D, who was recruited in 1995, passed through the washout period without any exposure. then developed hypertension in 2004, subsequently developed depression in 2014. So that is the patient. Now, we will try to match that patient to a similar individual of the same age who did not develop that exposure. So we look at patient 1, who again went through the washout period without any diagnosis, then went through the whole study period without developing an exposure, which is the development of any medical condition. So he is an eligible match for the patient A. Now, if you have to look at patient B developed an exposure to epilepsy in 2005. So this is not an ideal match because he's developed a different condition. So the matching is done based on the same age and sex for someone who has not developed the same exposure that the patient has developed. So each exposure, they have tried to match it to another patient of the same age who did not develop the exposure. Our sample size calculation, they have not actually calculated the sample size for this study. Now, in the supplementary table, they have actually described the stroke checklist, and they have said that they have given the sample size calculation on page 7, but it is actually not mentioned in the supplementary article itself or in the main article. The statistical methods they have used should also be described in detail. So, for instance, in this study, they have pre-specified subgroup analysis has been given in the study protocol itself. Now they've specified 3 subgroups, which is age intervals 10 to 19, 20 to 39, and more than 80, because one of the hypotheses was that older people have a higher risk of depression. The second subgroups that they've looked at are men and women. And the third subgroup they have looked at is the clinical setting, whether the patient was diagnosed with depression in a hospital setting, meaning the depression was much more severe, or whether it was in an outpatient setting. Now, each of these subgroups, they have analyzed in 3 specific panels, which is panel A, B, C. They have looked at the hazard ratios for major depressive disorder after a medical condition. They looked at the time-dependent hazard ratios, meaning is the depression risk highest within the first 1 month, or does the depression occur later? Is it 1 year, 2 years, or 5 years later? The panel C, they have looked at is the overall cumulative incidence in each subgroup. So each of these ratios is calculated for each of these individual subgroups. Now, the other components of the record checklist are that the authors should describe how much access the investigators had to the study database. Did they have free reign? Could they access any patient, any data from 1995 to 2002? Could they access anything? Or were they allowed to give only the specific codes of interest that they wanted, and could they extract only that data? Unfortunately, this study, they have not described how much access they were allowed to the original database. They've only given this line, which states that approval from the Danish Data Protection Agency was obtained, and that the country's laws do not require participant consent or ethical approval for registry studies. But how much access do they have not told us clearly. And this database they have used are the National Patient Registry, Civil Registration System, and the Labor Market Account. Coming to the results of the study, a total of 6,528,353 individuals were included in the cohort. Overall, the cohort was followed up for over 100 million patient years. So out of the 6 million patients, the exposure which we are looking at, which is development of any medical condition, occurred in approximately 2 million or 32% of the individuals, and depression occurred in about 1 million individuals. Now keep in mind that this 1 million is not entirely from the 2 million. Depression may have occurred in someone who did not have a medical condition at all. So in our analysis, we have to look at what is the risk in the exposed group versus the risk in the unexposed group and calculate whether that is significant or not. Now, ideally, they should have given us a baseline characteristics of the overall group. They also should have given a flowchart saying in 1995, they had so many people in their study. Then a certain number of patients developed the outcome of interest, and in 2000, these many were excluded. Unfortunately, they have not given us that flowchart. They do have given us a baseline table. So we just look at one table just to explain this. So for instance, we look at hypertension during the washout period, which we said was 5 years. So out of all the patients, we said 6 million patients were included in the study. Out of that 6,706,000 developed hypertension during the washout period. So this 700,000 would not have been included in the hypertension analysis, but they may have been included in the other disease analysis. Also, 288,000 developed major depressive disorder during the washout period. So they would not have been included in any of the subsequent analysis. Then, post the washout period, we are left with 5,921,000 individuals who are at risk, who have not been exposed. These were then followed up, and out of this 1,234,000 developed hypertension during which is the exposure of interest. And subsequent to that, 943,000 developed depression, which is our outcome of interest. And the overall time that the subgroup was followed up was 93 million years. So coming to the results. So here they have given us the hazard ratios for each subgroup that we have pre-specified. Now, at the bottom of the x-axis, you have the hazard ratios, which is the baseline of 1 and a hazard ratio of 2, 4, and 8. Now, if you look at the gender differences between men and women, men appear to have a higher hazard ratio, which is approximately 3. If you look at the age group intervals, the pre-specified, the hypothesis they had stated was that elderly people would have a higher risk, which bears out in the results. Patients over 80 had a hazard ratio of close to 4 for the development of depression, whereas younger individuals had slightly lower hazard ratios. Now, interestingly, the number of medical conditions also had an effect on the hazard ratio of the risk of development of depression. Patients with a single medical condition had a risk of around 2.2, whereas as the number of medical conditions that they have increases, the risk of developing depression also increases. And for specific medical conditions, the hazard ratios are calculated. Surprisingly, the highest hazard ratio was found for musculoskeletal conditions, which the authors have theorized was because they cause higher amount of pain and disability to the patients. Possibly that also could conclude that that was the reason for the higher incidence of depression seen in this particular group. The time period from the onset of medical condition, remember this was also one area of interest we wanted to look at. After diagnosis of major medical condition, is the risk of depression highest in the first few weeks or months after the diagnosis, or does it develop much later after the diagnosis? Our clinical scenario also, the patient developed depression within a month. That is borne out by this results, which states that the hazard risk of depression is highest within the first 1 month after receiving a serious diagnosis. The risk of almost over 4, and that risk of developing depression subsequently goes down in subsequent years, but never quite reaches the baseline. As we said, the number of medical conditions also have an effect with more morbidity, more medical conditions having a possibly leading to more disability, having a higher risk of developing depression. And the age intervals also, with higher age groups having more disability, being at a higher risk for developing depression. For specific diseases, we found that musculoskeletal conditions had the highest risk. That was followed by hematological conditions and malignancies, which is expected given the high morbidity and associated with these conditions. Lastly, the gender differences between men and women. The blue line is men with depression, red line is men with depression, and the interrupted blue lines are baseline men and women who do not have any medical condition. So obviously, clearly compared to the baseline risk of developing depression, patients who have a medical condition clearly have a much higher incidence, almost 10% higher incidence of depression. Now, one important thing is that this study, the way they had extracted the data from the study, for specific diseases, they had specific ICD codes. However, they had also looked at patient prescriptions to diagnose conditions. So to look at patients who had the outcome of interest, which was depression, they looked at the ICD codes for depression. They also looked at the prescription. So if any patient got an antidepressant drug more than 2 times in a year, that patient was also considered to have depression and was included in the study. Now, the pitfalls of that is that you may give an antidepressant drug for neuropathic pain or for some other condition, may not necessarily be for depression. So that may have actually overestimated the outcome of interest. But at the same time, not all patients with depression are given medication. Some of them may just be given counseling or cognitive behavioral therapy. So overall, the authors felt that it was a balance. Now, but that was a limitation factor for this particular study in that the outcome was not accurately calculated. So to overcome this, they have done a subgroup analysis where they have looked only at the ICD codes and calculated the hazard ratios. So the ICD codes would have been given only for patients who are hospitalized and received a clinical diagnosis of depression. So they did a subgroup analysis on those group of patients and said, does it really differ from our overall results? And the subgroup analysis showed that there's not a significant difference. You still got the same hazard ratios. So therefore, they concluded that the overall results, where they looked at prescription data, was still valid. What are the limitations of this study? One of the major limitations is that it's an observational study. Therefore, we can only make an association. We cannot say it's causation. We don't have the baseline ethnicity data of these patients. And like all registry-based studies, it is prone to misclassification. The source of funding and the role of the funders. This was a Danish Hospital Research Council which funded the study. They did not have any role in the publication of the data itself. And the access to this data was provided by Statistics Denmark, which is subject to approval from the Danish Health Ministry. But if someone wishes to replicate the study, they can approach the same authority and gain access to the same data. Coming back to a clinical scenario where we have a 65-year-old gentleman who was diagnosed with depression after receiving a diagnosis of atrial fibrillation. The questions we wanted to look at were does being diagnosed with a major medical condition precipitate depression? The second thing we wanted to look at was, are there any specific conditions that have a higher risk? So we look at the Bradford Hill criteria to answer these. So one of the criteria is that the strength of the association is important. The stronger association are more likely to be causal. Remember, we got a hazard ratio of 2.26 for the development of depression, which is fairly significant. So I will give that a yes. Now, is it consistent? Meaning, have the same observation be repeated elsewhere? So we do have multiple studies. One of the important studies is this relation between depression and metabolic syndrome. There are multiple studies corroborating the evidence from this study. So we will give that a yes as well. Is it specific? Is depression caused only by the development of a medical condition? That is clearly no, because there are other factors also that can. So this association is not specific. There are other factors that influence the development of depression as well. So this, I will say, is not a specific association. Is there a temporal sequence? Does depression always occur after a medical condition? No. There are situations where patients develop depression without any associated medical condition. They may develop a medical diagnosis later after the onset of depression. So yeah, this study, because they had excluded patients who developed depression prior.
This study, the temporal sequence is maintained.
Was there a biological gradient? Yes, we did notice that with multiple medical diagnoses, the risk of depression did go up. So there is a biological gradient. Is it biologically plausible? Yes, we can assume that patients who have given a severe debilitating diagnosis may develop depression. Is it coherent? Does it conflict with any pre-existing knowledge that we have? No, it fits in with our clinical knowledge as well, where we have seen patients who develop depression subsequently. Is there any evidence from experiments that can support causality? So what do they mean by experiments that can support causality? So are there any studies that have looked at, do healthier patients have a lower risk of depression? So when I search for studies, I cannot find it specifically for healthier, but there are multiple studies that show patients who exercise more or eat healthier do have a lower risk of depression. We can conclude that there are other experimental studies that have shown causality. Now, can you give a similar analogy that can explain this? We know that patients who develop a major diagnosis like a cancer diagnosis can precipitate depression. So we can conclude that the other illnesses like metabolic conditions, neuropathic conditions may also, which affect the patient's quality of life, may also precipitate depression. So to answer our two questions, do chronic medical conditions precipitate major depressive disorder? Yes, we got a hazard ratio of 2.26 after the diagnosis of major medical condition. And there is a proportionate increase with each additional diagnosis that the patient receives. Other specific diseases that carry a higher risk, that was one question we wanted, and we saw that musculoskeletal conditions and malignancies have the highest risk of causing